All right, so we are back with another PCBH Corner, and I am so pumped to introduce you guys to one of our fantastic family medicine physicians, Dr. Brooke Steadman. And I think we have a very, very special episode because we are going to be talking about the perspective of a PCP and how essentially she utilizes BHC. So I have a question just to kind of kick this off.
Okay.
All right, so I want you to imagine that there's a warm handoff, that you actually get the BHC on the warm handoff. They go into the visit and they come out and they say a response, something along the lines of, yeah, we weren't really able to come up with a plan because their presentation was too complex. I have referred them out to specialty mental health. Yeah, do you have any thoughts on that?
Well, my first thought is they're not going to be seen for months. So what can we do now? And that seems like a weird scenario because I almost never hear that.
I was going to say...
So I'm imagining a very imaginary story.
This is absolutely this was a leading question. But yeah, have you had a situation like that where BHC said, you know, I can't help them, and they don't reveal anything about their context, and they just basically come out and say, you know, I had to refer them out. There wasn't anything we were able to do today. Have you had that experience?
I've definitely never had that experience. Okay. The experience I have had would be the presentation of this incredibly complex patient with a very complex history and ACEs and trauma, and here is this patient, what you need to know about them, here's where we're working today and where we will continue to work, and I feel like getting them over to a specialty services for true psychiatric care in addition to what we're doing here it's still just adding one more member to the team. We're not eliminating ourselves from the care.
Oh, that's awesome. So I'm just really, really curious. So as a PCP, you guys get used to working with very complex patients, medically, psychosocially, all of the above, even though I know they say primary care is for Actually, that was one of the things
comical.
that I brought up to you when we were talking before we started filming was I was like, yeah, so primary care might be mild to moderate problems. Yeah, we talked.
I didn't even know it was viewed that way. And maybe if that's written somewhere, that feels silly and very outdated information. I'm not sure who in primary care is only managing mild to moderate problems, because there's just access is such a problem everywhere for specialty care of any type, and we present primary care as your home hub of like, this is where you come back and we can help coordinate that care, or, you know, figure out who you need to be with, and sort of the collector of all of the data that's being presented about this patient.
Right.
Because sometimes they'll come in and go, I saw my pulmonologist. I have no idea what happened. Do you happen to have the note, and can you walk me through the visit? And I mean, are we jumping outside of structured family medicine? Yes, and I would argue we do it every 15 minutes. I was gonna ask you, how often, if you're in clinic for the full day, so that you have 20 patients scheduled, how many out of that 20, if you had to like have a guesstimate, on average would have a pretty decently complex medical and psychosocial context? On any given day, I mean, I think we're talking somewhere from 50 to 75%.
Okay. Yeah, so this idea that like, hey, the vast majority are going to be mild to moderate, and then there's this little sliver that's severe, and then when there is severe...
I think I said it the other way around.
Oh, wait.
I'm sorry.
Oh, that's okay.
I think what I meant of like, I think somewhere between 50 and 75% of the patients will have a moderate to severe presentation.
No, you said it right.
I did.
Oh, yeah, okay, you said it right. You said it right. Yeah, so the idea that maybe is being pushed out there, that's the opposite, that like, hey, this tiny little sliver is going to be mild to moderate, and then you get into practice and you're like, moderate to severe is like kind of, more
that becomes
common.
way more the norm. And I would also argue that maybe that 50 to 25%, 25 to 50% that's coming in and you're expecting it to be mild to moderate, if you really dive in, if the time allows, if the presentation like needs you to go there, you're discovering that we're all just too complex to be put in a mild box, you know? I mean, the presentation of today's moment of like this small rash or something could be mild, and the person underneath that is more complex than that.
That's extremely well said. Extremely, extremely well said. So as a PCP, I know that you refer a ton to us as BHCs. You have clinic this afternoon. I have clinic this afternoon, which is really exciting. I'm sure we'll get some warm handoffs. What would you say if you had to imagine a scenario where what we were talking about earlier, where you asked one of us to come in and help, and we either turned it down and said, well, you know, that sounds too complex, or we went in, did the visit, came out, and the only information that was shared was something along the lines of like, yeah, well, there's nothing we can get done today. How many times would that need to happen before you basically like stopped utilizing us?
I don't think it would push me to stop utilizing it because of what I know about how things go and are expected here. If it happened once, I would ask for some additional assistance. I would go, I think that we got our wires crossed. What is happening in this room? So maybe that's just the way I'm conditioned of like, I would find another avenue to get us there. But if that was consistently the message, or that was what the expectation was, that was kind of allowable, only a couple times, because that would be really disheartening, especially if you try to talk the patient up into it. You know, you're like, I have somebody who's so excited to see you, and they're going to help you with insert, you know, concern here, stress, sleep, diabetes, whatever it is that's got going on. And they're like, yeah, sure, I'm excited to meet someone who's excited to meet me. And then they're like, can't help you. Like, that's just like a door slamming in your face for both the patient and the provider.
Oh my gosh, that is such a good point. So even if, my brain's going like 10 different directions. So yeah, it would only take a couple times if you came to me and said like, hey, here's what the BHCs are doing and here's how they're reacting. It would only take a couple times. Like, and if I said, well, Brooke, we've actually, Dr. Steadman, we've changed our system.
Right,
We're going to
scaled back.
We've scaled back. You'd be like, okay.
Right. And then you're having to do a mental cherry pick of like, who can I ask for help? What are the problems that are acceptable to be a handoff? I mean, I've been under the impression that no handoff is too small.
And that is the right impression. Now that is so exciting and super great. So in many systems that there's PCPs, and maybe there's a BHC who are new to the setup. So maybe it's not as mature or robust as maybe our program, right? So maybe imagine you're a PCP in a system and there's like 10 of you guys, 10 PCPs on at a given time, and you welcome your first BHC. How would having one BHC versus having like maybe 4 BHCs available, how would that impact your warm handoff practice?
Yeah, I think that when you run into the times of one person needing to be utilized for a whole group of people, meaning a whole group of patients, you know, every one PCP seeing 10 patients per half day or 20 patients in a whole day for one person to see that, it's overwhelming to say all of those numbers and think about all those patients. And so I do think you would have to start to get really granular of, okay, well, I want these 3 patients in the 3 rooms I have available to see BHC for a various complaint or another, but this one needs it most. And you're having to make that decision for people, and in some cases it can feel kind of overwhelming to make that choice, or only seeing the ability to hand off the people that are in the most despair, like your true in the moment suicidal ideation patients.
So when the staffing ratios are maybe in their infancy and they're not the greatest, ironically what happens is our BHCs are going to be asked to probably deal with the most severe situation.
Yeah, most acute presentations.
Most acute presentation. Yeah, and you know, in the beginning of many integrated care, that's how it goes. And so we need to be equipped as BHCs to get started, while we then advocate for building up a bigger and bigger team. And we need to not be freaked out by complex presentation, especially very complex presentations. So from your work with BHCs, you know, you're an honorary BHC, of course, but I know you are trained as a family medicine physician. Is there? It's
like I'm a BHC with family medicine background. Like I've morphed a little bit.
And so, is there anything that from working with us BHCs, as well as, you know, didactics and one-on-ones over the years, because Dr. Steadman also did her 3 years of family medicine residency at CHCW. Are there any major takeaways from the BHCs that you've learned for how to kind of for how you can even manage these complex psychosocial presentations?
The thing that rings the most true to me is, context being the key portion. If you don't know where the person in front of you is at in that very specific moment in time, your recommendations can fall on deaf ears, and they're not shared decision-making plans, which in family med is really important, and that's what we do as well. It's always a shared decision-making moment, and so if you are just do this, it becomes really authoritative, and people are more likely to go, okay, and then leave. You have no buy-in. You're trying so hard to build that rapport, and you potentially squashed it right in the last couple minutes.
Right. Because
you're doing all this stuff of like, oh yeah, we're a team, and then you're like, take this medicine and go, or go to the gym 5 days a week, and they're like, oh, okay, that's a person who thought they heard me or pretended like they heard me, and then you just lost that relationship. So that's super awesome. I don't mean to interrupt. I just got super excited because I was thinking about, I know that you're very dedicated to evidence-based medicine and having, rationales and reason behind the medicine you do. So how do you in your head reconcile when you know that the recommendations for, physical activity would be 30 minutes a day of moderate intensity exercise over a 5-day period, that's going to give a patient the biggest bang for their buck. But like you just said, you go in, you get the context, or the BHC gets the context, we all get the context, and we basically ascertain, like, there's no way this person is only getting, we're lucky if a couple of minutes, and it's definitely not moderate intensity. How do you reconcile that, or how do you bridge that gap to like... I use a different approach with different patients, but one that I find works pretty well is to say that recommendation. Say that thing I know you've had beaten into your head 10 times by other providers, or maybe even by me in a different visit, or something of like 30 minutes a day, moderate intensity. Like, you say it and you almost go, is that doable right now? And both of us can go no at the same time and just go, whew, glad we got that off the table. So that, like, maybe that's our long-term overarching goal, but where are we going to start?
And you knew it was no because of the
context, yeah. Or if they were like, yeah, I do that, or, whatever, then great if you have that information. But either I've obtained that, or, one of you guys have, and we've collaborated as a team to go, okay, where are they at right now, and where can they go? Of saying that to the patient, of where are you at right now? And where can you go? I mean, like, I don't have to be the person that fills in those blanks. And to get the buy-in, really, the other person should say, this is where I'm at, and this is where I can go.
Actually...
yeah, something achievable. I mean, it's a smart goal in the moment without having to, like, yes, writing them down and being aware that it's a smart goal is great. And not all of our patients are really in a space to do that.
Okay, so before the recording, you and I were making that joke about in primary care, it's about functionality versus... it being about going into remission.
Right.
And we were like, in the way you're talking about just kind of doing one step at a time. Yeah. And maybe this isn't an issue for medicine. Maybe this is an issue more for the behavioral health field, that we get beat into our head in graduate school, that you're going to come in, you're going to meet with a patient, you're going to diagnose, you're going to do your intake, you're going to do your diagnosis, you're going to do your treatment plan, and then your goal is to get a patient into remission.
Right.
After working in primary care, I don't really think about things like that anymore. I think about it more along the lines of exactly what we're talking about, is meeting a patient where they are and helping them with their functioning. Does it I don't know, bother you as a physician if we come out and we say, like, yeah, they're going to probably stay pretty symptomatic, but we got them going the right direction? Like, what is your take as a physician?
Going in the right direction, I think, is all you can ask for anybody ever. It's the try your best model. And like, I think that if we strive to get people into remission or to solve a problem, it's like it's treating a whole person as a problem that they need to be fixed. And if we're saying, like, you are not a problem, your diabetes is not well managed right now, this whole team, as myself and our nurses, our MAs, our behavioral health consultants, any of our specialists we refer out to, like, we all have to work together in some form or another. And it can be okay for everybody to have their area of focus.
Right.
And as long as we're trying to move towards the ultimate goal as best we can. And if the patient is in the pre-contemplative state of change for all of those things, the best you can do is be with them, right? I mean, if we turn our back on the care, well, without us, it's not going to get any better. With us, we hope we can make small chip away best we can. But I just think that visit to visit, patients change because people change. And so what might not work last July, saying it again of, hey, I know previously when we've talked about this, we weren't really able to make some nutritional changes, but I just wanted to see where you were at with that now.
Right.
It's a gentle question. I don't see
like
that being something that is aggressive unless it's like, well, your diet's the problem.
Yeah.
Two things that basically meant the same thing and said in such a different way of someone going, yeah, no, I'm not really ready to change that yet. And you're like, that's okay. What else can we talk about? Makes it so that it's not like, well, you're hopeless.
One is disengaging the patient, the other is engaging the patient.
Yeah.
And you're choosing, as a physician on a regular basis, to have patient engagement.
And the more we look engaged, the more they will. Because once again, if I sit back and I go, you're not going to change your diet, right? You already said that. It's like once I've given up on you too, and I've said it.
Oh,
I've said it with my
man.
body, with my words, with my everything, and a closed statement. It was a statement, right? It wasn't even a question.
I just got chills of the thought of that, of the importance of in this moment, and this goes back to maybe something I can't remember if we were actually recording or we were just talking about it. It goes back. I think we were recording. It goes back to when you were saying about if you just walk in and be like, oh, sorry, I can't help you.
Yeah.
Versus,
whether with your words or your vibe, right? Or whatever you want to call vibe. But
and even if you did do a referral to specialty care,
right.
It's as a supplement. It's as additional.
Right.
I'm still.
It's not ever in place of, or it shouldn't be in most cases, because they should come back to their hub and come back to kind of their home-based team and go, this is what was happening. Where else can we work on things?
And ideally, so if this is the hub and the BHC is a member of that team, that goes for us BHCs too. So for folks who are out there who maybe have heard during the training, well, if it gets this many visits or we got to refer out, you might ask for specialty care support, but it doesn't mean that now you're done.
Yeah, you're not eliminating yourself.
As much as you are being an honorary BHC by all the stuff you said, by the way, just dropping that pre-contemplative, dropping the aces like it's nothing. We need to take a page out of the family medicine book of the longitudinal, comprehensive coordination of care. And when something comes up, people think of us. As the first contact. So we need to steal, as BHCs, we need to steal that from our physician friends.
Yeah.
Okay, so we've had an amazing conversation. I'm super pumped up right now, and I couldn't be more proud.
I know. One of your little minions has grown up, right?
Flourishing
Yes.
and flying the nest. Is there anything else that you'd like to make a point on, or anything else that we haven't talked about that you're like, you know what, at the end of the day, I would want a group full of BHCs and folks trying to do integrated care to know this about?
Something I've said before is that I think that the limits of PCBH and the PCP BHC team is in your mind. You can easily walk out of a visit and go, oh, I don't think they need BHC. And my argument to that is, what does that mean? I don't actually understand that statement. What does that mean? Oh, it was just this problem. It's like that is a dismissive statement in and of itself. The word just it can be hurtful to say that that's all you're here for, or give that impression once again, right? That somebody doesn't need help in another aspect of their life, and just because what they came in for you might be right, what they came in for might not be that problem, or might not be a problem that needs anything additional, but this is a whole person, and the thing they came in for is one tiny sliver of who they are and what they have going on. So the combination of worn handoffs or cold crashes or whatever it is we can do to meet the patient where they're at in the moment and go, what else is going on?
How else can I?
That is cracking open that door to knowing that person and not the problem.
What motivates you when it seems like, there's no major acute issues and things are decently stable, both medically and psychosocially, to get BHC involved? Because I know that you have multiple times of just saying hey, this thing is stable, but I would imagine living with this could be difficult. Do you want to go do a contextual interview? Or maybe a brand new patient who has some, well, sometimes we have the problem list, I think sometimes we don't. Just hey, go talk to them and just kind of see what motivates you to continue to involve BHC, even if there isn't anything that's glaring in your face.
Yeah. I know that my patients receive better care when we all work together. I know that. I know that between what you gather from a visit, what I gather from a visit, between the way I write my notes, you write your notes, the way we can talk about it and have, sometimes there's just the moments of, you know this patient, can I bounce something off of you that's going on with them? Like, you have another person who's able to go, yes, that makes sense for them, or that doesn't make sense. Maybe something else is going on. And I just think that, especially primary care, because we're so busy and so much of an access problem and short visits, and our patients are so complex, of having it be like, oh, I'm the provider, I'm living in this tiny bubble and I'm going into every patient room by myself. And it's like, no, I want to pop that bubble. I'm working with my MA, I'm working with my nursing team, I'm working with my behavioral health team, my other colleagues that, hey, I need to bounce this idea off of you, get like a curbside consultation, if you will. It's like, when we take the siloing out, we all work together, and I know patients do better in those scenarios because one brain can't hold it all in.
It's amazing imagery. Like, as you're talking, I'm like, the cool thing about it is I actually, Brooke and I actually work together. So like, I was picturing her going in and out of the rooms, and then like us talking in the hallway, or like catching up at the end of the day and being like, hey, what was going, like, I don't know. It was really cool. I got to picture it. I hope for those of you guys watching that you're picturing it too. And if you're not able to picture it, I hope that you work with...
Start picturing it. Start making it happen.
Yeah, work with your administration, or if you're in that leadership position, to kind of start working towards this, because this is the only way it's going to be uptaken.
Yeah.
If we come in as BHCs and we put limits on, I can't help with this, I can't help with that. Right. Everybody is an automatic referral out, and not necessarily even like, hey, we're all part of the team still, just kind of like, okay, triage and refer. Mm-hmm. I mean, there's not going to be really a reason for a PCP even
where is the benefit there? What are we getting out of it? The patient, what is the patient? They're having a longer visit, we're trying to do a handoff to get some more information, nothing else came out of it. It's like, I'm not sure what the purpose of that is, except for in those really acute moments where, if you helped one person that day, then great, but trying to do that mental triage of like, well, I wonder what all my colleagues are seeing today, and if their patients are having higher acuity problems. That's a lot of things to juggle all at once of where you're at.
And PCPs are some of the most practical people on the earth, because, I think in general, they're just very practical folks, analytic minds. Probably. And then they're put into a context that is very high pressure and fast paced. Mm-hmm. And so the very first thing that goes is impractical things in that environment. Right. And as a BHC, if you make yourself impractical, or you make your service impractical, they're not going to utilize you. Right. And I'm not trying to blame anybody. We're just having a conversation here. Whereas when you make yourself practical, then all of a sudden you're like, hey, you're reinforced to utilize us even more.
Definitely.
So.
Yeah, definitely.
All right. Well, awesome. I hope that you all are as pumped up as I am after this conversation. Thank you so much, Dr. Steadman, for your wonderful imagery and contributions.
I appreciate you having me.
All righty.